Oh, thank you, and good morning, everybody. It really is my privilege to be here this morning to represent paramedics from across the state of New South Wales and give you a little bit of insight into some of the things that happen behind the scenes when you pick up that telephone and some of the things that we're doing in partnerships with local health districts and communities across the state. So access to ambulance services is fairly universal. In fact, in Australia since 1961, we've had access to the 000 network and two slightly lesser known numbers, 112 for digital mobiles and 106 for text-based assistance or for hearing impaired individuals. And that will generate about 8.5 million calls to the emergency call service per year. New South Wales Ambulance will answer an emergency 000 call about once every 26 seconds. So as we go through this short presentation today, a number of emergencies, literally from Bondi to Broken Hill and Tweed Heads to Tathra, will be answered by our 4 control centres spread across the state. The view of New South Wales Ambulance is that treatment starts at the time of call, and location information is one of the most critical elements that we need to rapidly ascertain in order to be able to mount a response. In addition to the location of the emergency, the problem, which is generally elicited from scripted questions from our call takers, from the caller, will determine the priority of the ambulance response or the number of resources, particularly where specialist resources may be required. But most importantly of all, in life-threatening emergencies, which represent about 10% of all our work, pre-arrival advice can be provided over the phone by the call takers. These are the people that the patients, the family and the bystanders will never see, but they become a vital link into the health and well-being of the individual affected by that particular incident. Calling 000 is easy. In fact, it's very, very easy. And every year across the state and in fact across the country, we'll have a number of examples where very young children will call 000 to gain assistance from the emergency services for an event that is happening around them or near them. Mum's collapsed on the floor, dad's outside in the shed under the car. So 000 is an easy thing to do. There are a number of resources available and I'll provide some of them at the end of the presentation. So if you have children yourselves or grandchildren or children that are visiting, 5 or 10 minutes spent in a bit of a role play, surfing the website or downloading one of the apps may just mean that when push comes to shove and there is a critical emergency in their community, they will be the ones that will be able to access the system and turn on and get help to you. Now, several people, in fact, potentially most people in the room will know the curse of the mobile phone and how they follow us around, and some of us have used one or more of the devices on the screen there as they started to shrink and then the vogue was for them to become bigger. But emergency calls to emergency 000 from mobile phones are particularly problematic for emergency services across the country. On the last figures that are available, nearly 70% of all calls to emergency 000 now emanate from a mobile phone. Now, if you're in George Street in Sydney and there's one incident or one person collapsed, that can elicit 2, 10 or 20 calls to emergency services to mount a response. So whilst accessibility to the telephone network is generally an advantage, it also produces some fairly unique challenges. Of course, unlike the copper-based landline, where generally people know where they are, it's not uncommon at all now for emergency services to face the dilemma of, quick, send an ambulance, where are you? I'm not sure. I'm looking around for a landmark, I don't know where I am. So fortunately, technology has assisted here, and if we could take from Tony's talk the message about quad bikes and children to keep people safe, in terms of accessing emergency services, if you have particularly a smartphone device equipped with GPS capabilities, then downloading the Emergency Plus app will provide not only latitude and longitude coordinates for your location, but also map for wherever you are, as we see down here, an address that can be provided verbally to the emergency service call taker. Australia is rolling out an ability across the mobile phone network to gather that information automatically, but that's not operating in all states of Australia at this time, and there are some remaining technology limitations with that. So knowledge of your location or an ability to pull that location down from your device and provide it to the operator can certainly assist with mounting a speedy response. So we've heard of a lot of smart devices, and one of the things that an increasing number of vehicles available on the Australian market have is some automated technology on board. In fact, this particular vehicle can call emergency services in the event of a crash without any intervention from the driver at all. It's not just the high-end vehicles that are rolling out this technology, so you don't have to drive a BMW. Ford, General Motors, Holden and Hyundai all have their own variants or their own brand name technologies that operate under this. They can do things like provide information to emergency call centres about the number of seatbelts that were engaged in the vehicle, therefore giving a good idea about the number of people that might be on board. They have G-rated sensors to determine the forces involved in the crash, and some of the technologies can even tell you if the vehicle has been involved in a rollover incident, which may indicate the need for rescue or other specialist services. So truly we are surrounded by an Internet of Things and a connected Internet of Things where manual intervention is not always required. The other thing that I think we've seen a significant explosion of is health-related apps. This slide, which is now some 6 months out of date, estimates that there are over 17 or 18,000 individual applications that will run on smartphones, providing a whole range of health-related information to the user, and potentially that information can be shared with healthcare providers, most normally primary care providers like general practitioners, but also into the future the potential to share that information with emergency services. In fact, if you've heard any of the technology stories around the Apple Watch launch recently, it's equipped with not only a heart rate sensor but an ability, pending FDA approval out of the United States, to measure the amount of oxygen circulating in your blood at any one time. So in November 2014, New South Wales Ambulance launched a new strategic plan, and we called it "Today is the Day that we make tomorrow different." And that was because as an organisation we recognised that the healthcare needs of communities were fundamentally changing, and that ambulance needed to keep pace with that change, and that the default option of an ambulance arriving with 2 paramedics on board and automatic transport to a hospital was not always in the best interest of the patient or the consumer, and was not always the most appropriate or effective way of delivering services to a community. Our strategic plan has 8 key elements, and it's from this we've built a number of our integrated care strategies. The first is that it's a mobile health service, and I stress at this point a mobile health service as opposed to perhaps the more traditional view of an emergency service, that we were patient-centred in everything that we did. We needed to be staff-focused and make sure that our staff were equipped with the relevant training, equipment and tools to undertake their tasks. We needed to deliver the right care, and this is really where we started to see a diversification away from a vanilla-based standardised care that ran out across the state to say what is it that particular communities need, and importantly what are the health services that the ambulance service is connecting with. Is it a tertiary hospital, is it a primary care centre, or is it a single allied health professional servicing a community that might be isolated by fire or flood? We believe that we need to be centrally coordinated and locally delivered, and increasingly we're decentralising management decision-making ability down to the local level, so that the local management teams can connect particularly with their LHDs and look at what the community needs are in that regard. We clearly need to be engaged. Unfortunately, ambulance has been one of the emergency services that has been very good at responding but has had little time to spend in the planning and preparation phase. So increasingly what we're seeing is a shift of resources whilst we maintain that level of emergency cover or emergency response, to take the time to sit down with communities, allied health providers, and determine what it is that is really required. We need the right infrastructure and support services, and as a mobile health service, whilst we need a base of operations, Really, it is mostly about the vehicles that we drive, having the appropriate vehicles and having the appropriate equipment inside those vehicles for the sorts of cases that we're attending. And inevitably, if we're going to have connectivity and be a part of a patient journey from start to finish, we need to be e-health enabled so that we can transfer patient-related information easily between other providers in the community who are providing service. And we always need to be innovating, because the service that we were providing 10, 15 or 20 years ago may not be the service that communities are looking for today. We believe that there are 4 main domains to our work, and that true life-threatening emergencies, that is those incidents where mounting a response in minutes and where seconds count, really only represent about 10% of our work. Along with colleagues in Victoria and in some of the provinces of Canada, there's an increasing body of research that suggests that up to 40% of the patients that we attend do not require an emergency ambulance, do not require degree qualified or tertiary qualified paramedics. There's no doubt that they require some form of response, and there's no doubt that they require some form of care, but this is really about tailoring the care to the specific circumstances that they encounter. A substantial part of our business is what we call urgent or unscheduled care. So we don't need to mount a response with lights and sirens, but we do need to send an appropriately qualified health professional around, often to make a hands-on assessment, and then we need to understand the network of health providers or services that are available, and to connect that patient with those services in the right time frame. We play an important role in supporting the health system, particularly with the secondary or tertiary transfer of patients between facilities, either as their care requirements increase or their care requirements decrease, and they're on that journey to return home. And we also have a part of our business that is about community support, where paradoxically there are no patients at all, but a significant amount of pre-planning needs to go into those events to be postured for a response in the event that it is required. And sadly, it's in this space, particularly in metropolitan areas, that Ambulance is investing more resources because of the counter-terrorism threats that Australia and other countries are facing. Most countries around the world have their own version of the number, and most countries around the world traditionally have had an ambulance service that is based upon a call and we will come response. And the challenging message today is that perhaps we need to break that promise to the community. Perhaps we don't need to mount a response physically to you at all, or perhaps we do need to mount a physical response, but instead of measuring that response in a matter of minutes, it might be more of a scheduled response that is sometime within the next 1, 2, 3 or 4 hours, depending upon your condition, and to make sure that we connect the right sort of clinician with the presentation that you're describing to our call takers. There have been many attempts in many jurisdictions to mount campaigns like "We're an ambulance service, not a taxi," and the evidence that is available suggests that has a limited effect in curtailing the amount of inappropriate access to emergency medical services. Sometimes there is an occasional dip, but inevitably the level of demand continues to keep on climbing. So if we can't stop the inappropriate calls, then what we can do as New South Wales Ambulance is stop the inappropriate responses and explore a greater menu of options to connect the right response to the patient presentation at the time. The reality is that there are not ambulances on every street corner, and particularly in settings like yours, the backup for an ambulance that requires additional resources may be coming from the next town or beyond. And the reality is also that if we don't have smarter ways of working, particularly with elective patient transfers out of hours, then what we're doing is taking that emergency ambulance crew out of that community for coverage overnight and drawing resources in from a far greater distance. So we've invested a significant amount of time and effort into a broad package of work that we call integrated care strategies, which is really about connecting with other healthcare providers in the system. And I really just want to provide a bit of an overview, a brief overview of some of those There's far greater detail available on any of these, and I'd be happy to take questions at the end or talk with you during one of the breaks if you have a particular area of interest. The first thing is I think the ageing population will be no surprise, and we need to make sure as an ambulance service that we're postured to meet the needs of aged care. There's no doubt there's an element of that is involved in mounting an emergency response, but very often it's about longer term care, and particularly for chronic conditions, and in areas that have reduced levels of healthcare or primary care services, ambulance can have a role here in monitoring healthy states and not just waiting for a degradation in a health state to result in the ambulance call. A significant part of tailoring our response, we coin the phrase, right care to the right patient in the right time frame, is about authorised care plans. And that's about making sure that we provide the right care to the right patient. So patients with particular conditions, we work closely with specialists or with GPs, and we can have an individual care plan in place where an element of their care might be something that is not normally offered within the ambulance scope of practice. Or it might be a patient that needs a far more significant pharmaceutical intervention that would normally exceed the standing order type arrangements that ambulance paramedics work with. It also provides for advanced care directives and for care of people in palliative care situations where health professionals in advance plan the care with the family that the patient will receive. Our extended care paramedics have an increased scope of practice. They have an ability to prescribe certain medications, to undertake basic suturing, and importantly they have an ability to refer into other health pathways and other systems and turn those systems on. Patient referrals and alternative destinations. Probably less than 10 years ago, the default destination if you got an ambulance ride was into your local emergency department. Last year on the central coast of New South Wales, we had a proof of concept to identify patients that did not require care in an emergency department but could be quite adequately managed by their GP. And we successfully undertook a number of referrals from the home setting into the primary care setting. We worked with the GPs in the area to have priority bookings because we know that access to a GP can be difficult within short time frames. And whilst the option was there for ambulance to transport the patient down to the general practice, we found that most patients were able to make alternative transport arrangements with family, friends or neighbours, thereby releasing the ambulance crew earlier to be available for the next emergency response in that community. In Western Sydney, as an extension of alternate referral pathways, we also had a 6-month proof of concept trial called the Mental Health Acute Assessment Team, where we took an extended care paramedic and a mental health nurse, put them on the same vehicle and responded them to a targeted set of incidences where we believe there was a high probability the patient was presenting with a mental health condition. A large number of assessments were taken at the scene, some of those with community referrals and some of those resulting in direct transport and admission into mental health facilities or wards, thereby avoiding a significant delay in the emergency department where the patient had to be assessed before they could move to the point of definitive care. We also have a program called Paramedic Connect, which is about connecting our paramedics with the communities and similar to my reference earlier, not waiting for that 000 call coming in, but particularly with isolated individuals who might have limited family support, looking at some basic health checks or basic health monitoring, things like blood pressure monitoring, blood glucose monitoring and nutrition to try and avoid an unnecessary access to the emergency part of the health system. We've also undertaken a body of work broadly called frequent user management. And that's because paramedics often have a unique insight into not only the medical needs but also the social needs of individuals who might be in crisis in the community. These are small in number in terms of our overall patient population, but one of our most significant frequent users accessed emergency 000 and we mounted an ambulance response in excess of 300 times in the space of 12 months. That's nearly every day we would attend this individual, make an assessment of their condition, leave them in that home setting, only to return either the next day or later that day. Frequent user management's a targeted intervention that brings together a network of health professionals and other professionals to assess the needs of the patient. What we've seen is that very often, whilst the call is for a medical condition, the underlying cause is more of a social cause or more of a coping cause. And if we can get access to the right sorts of community supports, simple things like Meals on Wheels, welfare calls a couple of times a week, family networks or supports, then we can significantly reduce the number of times those individuals will access the emergency 000 system and occupy a double ambulance crew. I don't propose to go through the next two slides in detail, but suffice to say that these are just some examples of the range of things that we're doing across the state. One of particular interest in this context is the CHESS, or chronic complex healthcare, and the engagement of stakeholders, connecting that critical flow of information between paramedics, GPs, patients and other care providers in a timely, accurate and secure way, so that whoever is dealing with the patient presentation at the time has all the latest available information. It's not unusual, particularly in country towns, for GPs to not be aware that the ambulance may have attended their patient on a number of occasions in recent times. And the paramedics can offer not only a unique insight into the medical presentation of the patient, but also those social circumstances that I represented earlier, thereby enabling the GP and other professionals to intervene or make sure that the needs of those patients are being met. Probably the single biggest change for New South Wales Ambulance is coming out of being an emergency service to being a mobile health service, and having not a transport concept of operations with this default transport into an emergency department, but taking care to the patient, and in instances where we can't provide the care, making the connections with other care professionals who can provide that care to the patient. We currently prioritise our calls with 17 different response priorities. We're undertaking a piece of work to reduce that, and our colleagues from the health system, particularly the emergency system, will be pleased to see that this is the final state that we'll be moving towards, and that is really a very close alignment with the Australasian Triage Scale, or ATS 1 to 5. You note that it's only the two priorities at the top of the slide there that actually require an urgent lights and sirens response. There's a body of work that requires a timely response, but should not be exposing paramedics or other road users or members of the public to the increased risk of urgent duty driving. And then there's a whole bundle of work in the urgent unscheduled care where we need to agree what that time frame is. And that time frame may be quite different from the time frame that ambulance has traditionally worked in, and the time frame that communities have traditionally expected. So that moves us really from a concept of here if you need us, because we'll always be there to pick up the phone. On 90% of occasions last year, we answered 000 calls in less than 10 seconds. And to be there if you really need us in terms of mounting a physical response, be it with ambulance paramedics in a traditional ambulance, other health professionals, or referrals to other networks who can provide physical attendance in an agreed time frame. Just one example of this is the home doctor service. There are a number of these popping up around the country. We've entered into a partnership agreement with two of these providers in the Greater Sydney metropolitan area, covering the Palm Beach to Cronulla and west towards Penrith and the Blue Mountains, to say whether that can be identified at the time of call, or whether in fact an ambulance paramedic crew attend the patient, make a physical assessment or determination themselves, rather than take that patient into the hospital, that the GP can attend. It's a bulk billed service that's available to patients, particularly after hours when other primary care services are not available or more challenging to access. But I mentioned that 10% of our work is truly life-threatening, minutes and seconds, it counts. So the chain of survival about early recognition of what a medical emergency is, early access in this country via the Emergency 000 network, basic life support in terms of CPR, defibrillation and then advanced life support. When we link up these 5 components, we provide an individual with a life-threatening emergency the greatest possible chance of survival. And that's where we can probably use the mobile phone for a piece of good. This crowdsourcing app, which is currently being beta tested and sandbox tested by New South Wales Ambulance, will alert members of the public with CPR training to an emergency that might be in their immediate vicinity. I think the harsh reality is that paramedics rarely save lives. It's often bystanders, particularly in those time-critical circumstances. And even if the ambulance response is 8 minutes away, then there could be someone just next door, there could be someone downstairs, there could be someone a block away from someone who collapses who urgently needs CPR. And if we can mobilise that person to the patient's side whilst we turn on the rest of the system and mount an emergency response, we really do have an ability to make a significant difference and improve out-of-hospital cardiac arrest survival rates in this state. Sadly, New South Wales Ambulance has had to mount a campaign in the last 12 months to alert the community to the fact that it's unacceptable for occupational violence against paramedics. We see as a result of alcohol and other drug-affected states that our paramedics, whilst they're mounting that life-saving emergency response, will be subject to assault. And the Commissioner and the Executive team have been resolute in their message to staff and the community that that's unacceptable on any level and that we will pursue those people through the courts to the greatest extent possible. The top site there, kids000.gov.au, that's a great place to go for some resources in terms of educating the younger generation about how to access Emergency 000. And there's also a range of information on the New South Wales Ambulance website that expands upon some of the things that I've touched briefly upon today. I'd be happy to take any questions from the floor.